Hemiplegia. General features. The most likely diagnosis is stroke, so look for evidence of vascular risk factors/disease, e.g. xanthelasma, corneal arcus, nicotine stains, scars on the chest or legs indicating surgery for ischemic heart disease, scars in the neck indicating previous carotid surgery, and the presence of a pacemaker. When introducing yourself to the patient, take particular note of how well he moves his limbs. Does he appear to have a visuospatial deficit, suggesting right parietal cortical involvement? You should also note the presence of speech and language problems. Aphasia is unlikely in a right-handed subject, but you do not yet know if he is right or left-handed. It is important to know if it is his dominant or non-dominant hand that is affected. Neurological examination. The neurological examination should be broken down into motor, sensory, visual and cognitive elements. Motor signs. The key features to look for include the following. Wasting. This may be present on the affected side due to disuse over time. Tone, usually increased on the affected side, may be normal or even reduced in the acute setting. Power. Typically power is reduced in a pyramidal distribution, upper limb extensors weaker than flexors and lower limb flexors weaker than extensors, hence the arm tends to be held in flexion with a hyperextended leg. Reflexes. These are increased on the affected side. Plantar response, extensor, upgoing, on the affected side. NB. Do not forget to examine the power of the facial muscles. If weakness is present on the opposite side to the limb weakness, this would suggest a brainstem stroke. If the weakness is on the same side, the damage is most likely in the middle cerebral artery territory. Sensory signs. Sensory signs are likely to be in the same distribution as the motor signs. Sensory loss has a negative impact on functional recovery, so it is important to assess it. Do not forget to assess proprioception, as impairment in this modality will cause specific difficulties with rehabilitation. Visual signs. The presence of a homonymous hemianopia has value in localizing the lesion site. Cognitive signs. Determine whether the patient has any deficit in either of the following domains. Language function. Briefly assess expressive and comprehension components. Visuospatial function. Briefly look for visual and/or sensory inattention and/or extinction. Once again, these features will have localizing value to either the dominant, language, or non-dominant, visuospatial, hemisphere, and they suggest cortical involvement in the damage. Note that cortical signs can be present when only the white matter adjacent to the intact cortex is damaged, as this can effectively disconnect the cortical area from afferent and efferent connections. It is crucial to be aware of the presence of cognitive signs when considering rehabilitation strategies. Further discussion. In a patient with hemiplegic stroke, the important questions are as follows. Where is the lesion? What is the pathology? What is the mechanism? Where is the lesion? Hemiplegia may be caused by a lesion affecting the cerebral cortex in the arterial territory of the anterior or middle cerebral artery, the deep white matter or the brainstem. The Oxfordshire Community Stroke Study, OCSS, classification is useful for determining the anatomical site of the lesion, Table 21. What is the pathology? Stroke is much the commonest cause of hemiparesis, but there are various stroke mimics that need to be considered, e.g. a space-occupying lesion, and in an acute setting, a seizure or hypoglycemia. It is important to make the distinction between an ischemic and a hemorrhagic stroke, but this cannot be reliably done by the bedside and neuroimaging is required to be certain. What is the mechanism? Stroke is broadly classified into ischemic and hemorrhagic. NB. It is not possible to distinguish an ischemic from a hemorrhagic stroke on the basis of the history and examination alone. Neuroimaging, usually with CT in the first instance, is the only reliable method of doing so. The OCSS subclassification cyst. Total anterior circulation syndrome, TACS. Site of infarction. Implies large cortical stroke in middle cerebral artery, or middle and anterior cerebral artery territories. Causing new higher cerebral dysfunction, e.g. dysphagia, dyscalculia, and visuospatial disorder, and homonymous visual field defect and motor and/or sensory deficit involving at least 2 of 3 areas of the face, arm, or leg on the side opposite the lesion. Partial anterior circulation syndrome, PACS. Site of infarction. Implies smaller cortical stroke in the middle or anterior cerebral artery territories. Causing patients with 2 of the 3 components of TACS or new higher cerebral dysfunction alone or a motor and sensory deficit more restricted than those classified as lax, e.g. isolated hand movement. Lacunar syndrome, lax. Site of infarction. Implies a subcortical stroke due to small vessel disease. Causing pure motor stroke, pure sensory stroke, combined sensory motor stroke, ataxic hemiparesis, dysarthria and clumsy hand. Note that evidence of higher cortical involvement or disturbance of consciousness excludes a lacunar syndrome. Posterior circulation syndrome, POCS. Causing ipsilateral cranial nerve palsy with contralateral motor and sensory deficit, bilateral motor and/or sensory deficit, disorder of conjugate eye movement, cerebellar dysfunction without ipsilateral pyramidal involvement, which if present is more likely to be ataxic hemiparesis, see lax. Isolated homonymous visual field defect. Ischemic stroke can be caused by thromboembolism from the heart or major vessels, or by occlusion of small penetrating cerebral vessels. The presence of atrial fibrillation or carotid brutes is helpful in indicating the likely source of embolus, which has implications for optimal secondary preventive strategies. Almost all cases of intracerebral hemorrhage are caused by one of the following. 1. Primary intracerebral bleeding 80 to 85%. Hypertension. Amyloid angiopathy in the elderly. 2. Primary intracerebral bleeding 15 to 20%. Hemorrhagic infarction. Ruptured saccular aneurysms or arteriovenous malformations. Associated with bleeding disorders. Eclampsia. Oral anticoagulation. Cerebral vasculitis. Tumors. 3. Rarer causes include trauma, cerebral vasculitis,